Echo is indicated in many clinical situations. For example, mama, unexplained mamas, patients from oncology, patients of coronary artery disease, suspected or documented valvular diseases, pulmonary diseases, in HIV, drug abusers, patients with history of drug abuse, IV, etc. Suspected cases of congenital diseases, all those ones, patients of AF, all those ones will have to undergo an echo exams. Those ones of hypertension, diabetes mellitus, systemic illnesses, and all those ones will undergo echo. So whatever we're going to talk about, it will be rotating about that one and what we'll be looking for in specific scenarios. We are starting. Before we start, please, if you like this video, don't forget to subscribe, like, comment, that more and more videos are still coming as far as cardiology is concerned. And then from here, we shall also touch into other topics not related to cardiology, like general physiology, everything. Here we can continue with our introduction. AHA and the ASE, they grouped these indications basing on the purpose of the examination. Is it to evaluate the cardiac structure, function, hemodynamics, or follow-up of known diseases? So in the following slides, we are going to go in details and see each component. And see each component. It's very important for the sonographer to know this because it saves time. You must know the indications because you go specifically to what is most likely to be the problem. And if it's not the one, then you can look for other stuff. But you know the target. It gives you the target, a hint. Number one, indications: cardiac chamber size and function. This one on most of the conditions, we assess these ones. Assessment of left and right ventricular sizes, wall thicknesses, that is sizes to exclude cardiomyopathies and dilations, thicknesses still cardiomyopathies, size for dilated, thickness for hypertrophic, systolic and diastolic function. Systolic, you measure EF, FS, and the fractional area change. This is fraction shortening, ejection fraction, fraction area change for systolic function. And then diastolic function, we measure EA ratio, E prime ratio, and then TR, and then pulmonary venous Doppler, etc. We shall measure. Then next is detection of wall motion abnormalities. In conditions of ischemia like coronary artery disease, and then where there's general hypokinesia like cardiomyopathies, for example, dilated cardiomyopathy or decompensated hypertensive heart disease, and then myocarditis. Myocarditis also present with generalized or global hypokinesia. Indication number 2 is valvular diseases. Valvular diseases, it may be suspected, like in patients with mamas. Patient with mama suspect a valvular disease. And the clinical symptoms of valvular diseases or non-valvular stenosis or regurgitations. You may be just for follow-up. You know this patient is RHD. Maybe initially it was mild MS with mild MR, and after 1 year, you have to do another echo to see the progression, and maybe this time it will be mild MR, will be RHD with moderate MS and mild MR, meaning the stenosis is progressing. Why is it important to follow up? To determine the most appropriate time for intervention. If you don't follow up, then you either do intervention very late, or it will be so early when it is not required. And then evaluation of patients with prosthetic valves. For example, post valve replacement, you have to assess the prosthetic valve, how the prosthetic valve is functioning. Is there no leak? Then after that one, are we getting more stenosis, another stenosis that he has to, again, to remove the valve? Are there pannus formation? Is it stacked? Are there thrombus? Like for infective endocarditis, called the normally form vegetations on prosthetic valves. Are there thrombi, etc.? Monitoring disease progression, have talked about that one. Then establishing the cause of the disease, finding the disease itself, for example, MR, AR, etc. Excuse me, I need more oxygen, the brain is complaining. We have to establish the cause. Only finding the valvular disease is not enough, but its cause is the most important. Is it a prolapse? Is it a flail? Is it a dilated annulus, etc.? Is it a RHD? Is it calcification? Is it bicuspid valve, or unicuspid, or tricuspid, or quadricuspid, etc.? You have to find the cause. Indication number 3 is coronary artery disease. As we said at the start, all patients either suspected or known. For example, suspected, those ones with chest pain, and they will be evaluated. And then those ones with myocardial infarction, either prior or post, they will be evaluated. For pre-procedure, for example, pre-PCI in acute MI, deciding the baseline EF, all motion abnormality, and confirming that there is no MI complications, mechanical complications of MI like ruptures, MR, etc. Post-procedure, to monitor the recovery of EF, all motion abnormality, and confirming that there is no MI-related complications like mechanical complications, aneurysms, thrombi, and then VSR, that's ruptures, or free walls ruptures. So you see those are different times in coronary artery disease when you do echo. Acute MI, pre, and then post. Ischemia, patients with chest pain, still we do. And then post-procedure also, we keep doing. Stress echo also for evaluation of ischemia, but there are other best ways to do no stress echo, but there are other best ways to do that. Indication number 4, there, heart failure and cardiomyopathies. Heart failure can be diastolic or systolic. Causes of systolic heart failure, it can be dilated cardiomyopathy or ischemic heart disease. It can cause systolic. Cause of diastolic heart failure, it is hypertrophic cardiomyopathy and then restrictive cardiomyopathy. And then that cardiomyopathy, which is CKD related. So in CKD patients, we expect to find a certain type of restriction, or like restrictive cardiomyopathy, renal or cardiomyopathy, that is renal origin, CKD related. In CKD, there are some deposition that is there in the myocardium, and it causes restriction. It makes the myocardium stiff. So that is some component of restriction. So it will appear like typical appearance of restrictive cardiomyopathy, where the thickness, myocardial thickness may be normal or increased, and then with biartery enlargement. So CKD patients will have diastolic dysfunction. That's one thing you must know. So in CKD patients, that's what you are looking for. EF is maintained, but diastolic dysfunction is there. Here, diagnosis and follow-up for patients with hypertrophic, evaluation of cardiac manifestations of infiltrative diseases like amyloidosis and sarcoidosis. For example, in patients with documented history of pulmonary sarcoidosis, higher chances it can move and also affect the heart. So you have to check. But there are other best tests to confirm that either there is deposition, amyloidosis, or sarcoidosis. There are other tests, that is nuclear cardiology, that is best at doing that one. Otherwise, we expect if there is amyloidosis and sarcoidosis, we can expect diastolic dysfunction to be there. And in amyloidosis, it has its typical appearance on echo, that is apical sparing. Apical sparing. Others to become hypokinetic from the base, mid, but the apex is spared. So you see the apex in amyloidosis, the apex is moving very well. And if we do the speckle tracking, you see properly that the apex is moving and these other segments, they are not. And they appear like sparkling white, sparkling myocardium is there. So we know that one. Indication number 5 is congenital heart disease. That is, in congenital heart disease, for initial diagnosis, majorly in pediatrics, for initial diagnosis, and then follow-up. When you diagnose, sometimes intervention is required there and then, or it is not severe, asymptomatic, or small, and then it just requires to be followed up until when intervention is required, or until when it closes spontaneously. So, in doing so, we are assessing the shunt size and volumes. If the shunt is very big, or a shunt volume is very big, then that is a severe defect and it needs to be closed. If it is small, the shunt volume is small, otherwise you can take its diameters or dimensions. If it is small, higher chances if it's in a pediatric, it can close spontaneously. So we wait for it to close spontaneously. For example, small muscular VSDs, they close spontaneously. Estimation of pulmonary artery pressure. Yes, estimation of pulmonary artery pressure in congenital diseases with either left to right shunt, it can increase the pulmonary artery pressure and then it causes reversal, or it causes shunt reversal. Initially it is left to right, and then with Eisenmenger syndrome, it goes back now. It changes the direction from right to left, and now it is going to cause cyanosis. At first it was a cyanotic. Now, when it shunt reverses, it will be cyanotic. I don't know if you understand. But if you read congenital disease, you will find 2 major classifications, cyanotic and acyanotic. But it can interchange. Indication number 6 or 5 Pericardial diseases. Pericardial disease, the simplest is pericardial effusion. It can be an effusion if it is chronically accumulating, or a tamponade if it is fast accumulating. Slowly accumulating is just an effusion, and then if it accumulates so fast, it is going to cause a tamponade. And then you have to confirm the tamponade physiology, compression of the right side chambers, etc. And then septal interdependence or respiratory interdependence of right and left chamber interdependence.